Good afternoon all. We are starting our next IC. I welcome Dr. Ashok Nadarajan and Dr. Anju Suresh to co-chair the session with me.
Yes, the first talk is, does this baby have any defective vision? Elucidating the milestones of visual maturation. Now I invite Dr. Anita Prabhakaran to deliver her talk. She's a senior pediatric ophthalmologist at Precise Eye Care Trivandrum.
A very good afternoon to one and all. First of all, let me thank KSOS for giving me this opportunity to have this IC. Many times we have many parents coming into our OPD deeply concerned about their child's vision. And we have often referral from pediatricians and from other colleagues, other ophthalmologists, and we may need to give them a definite opinion. A clear decision making is very much needed. So in this IC, we intend to take you, talk to you about what, where, when, and how of infant eye examination, various conditions and their management. We all know that children are not born with all the visual abilities they need for their life. And just like a child learns to walk and talk, over a period of time, they have to learn to see. And over every 2 months, they learn some kind of visual skill they acquire, and like focusing their eyes and moving their eyes more accurately, and to use their eyes more together as a team. And they use this information for stimulus as their growth as well. At birth, their vision is very less, at about 6/120, and it improves gradually over the few months. And only by the age of 2 years do they develop an adult visual acuity of 6/6. So we will just go through the normal visual maturation stages, because unless we know what is normal, we cannot identify or recognize what is abnormal, right? So we need to realize that at birth, the primary focus is on objects only 8 to 10 inches from the face, and that too, children cannot identify colors. They can only appreciate dark contrasting black and white images. By the age of 8 weeks or 2 months, they start to focus on their eyes on their parents' faces. And by 3 months, they begin to follow moving objects and start reaching for objects. And it's about by 5 months that they get their accommodation improves, their stereopsis improve, they get good color vision, and they have a better eye coordination as well. And when they start crawling at the age of 8 months, there is further development of the eye, hand, foot, body coordination. And it is supposed to, that parents should not, we should tell parents not to, fasten up and ask them to walk more quickly. Crawling has a role in even the eye development as well. So by about 10 months to 1 year, they are able to grasp objects and to judge distances much better. So just like it's not fair to expect an elephant to fly, we should not be expecting the milestones. We should know which all milestone to expect at what age, so that we can have a clear idea whether this child is normal or abnormal. So at each age, we need to do the age appropriate test, and as ophthalmologists, we have to know what all tests we can do at one particular age. So we have a preterm child coming to us. So here there are only two things we can do. One is a pupillary light reflex, and the other one is an external eye examination and a retina evaluation. So pupillary light reflex is possible, to elicit the pupillary light reflex from 29 weeks of gestation, and it shows an intact visual pathway, except that in cortical blindness it won't be contributory, and this should be done in all children. Now, when any child, like from newborn until 3 months of age, we have 9 tests we can do. Apart from pupillary reflex and the eye examination, we have blink reflex, red reflex, vestibulo-ocular reflex, eye popping test, fixing and following, OKN and VEP. So we regarding the external eye examination, it should be done in bright light with a torch. Meticulous hand hygiene, washing with soap and water is very important in examination of infants. Child should be well fed and comfortable, and the one eye should be examined first for any abnormalities, and then we should examine both eyes together to rule out if there is any asymmetry or any other conditions. So the typical eye appearance has to be made out and any abnormality to be detected. Next is a blinking light reflex, where we can see that when we show a very bright light onto a child's face, even when the child's eyes are closed, they will show some discomfort if the vision is good. Whereas if the vision is poor, How much ever bright light we throw onto the child's eyes, they will not show any kind of discomfort, and this is also very important test we can do. The red reflex test, we all know, distant direct ophthalmoscopy, and we need to have the aperture in full open and zero diopter. We stay about 25 to 40 centimeter away and look at the red reflex. There was in 2022 there was a universal eye screening which was initiated by WHO, in which they the pediatricians were encouraged to do the red reflex test and therefore detect the problems of newborns much earlier. Now, the doll's eye reflex or the vestibulo-ocular reflex, where the eyeball moves to the opposite direction as the head movement because of the semicircular canals and movement in the semicircular canals. And this test has to disappear once the fixation develops. Now, whenever we switch off the light in the room, the eyeball of the babies just pop out, and whenever we switch on, it again goes back to normal. So this can be again and again it can be elicited, and that is a very good test to know about the visual acuity. And fixing and following can be done until the age of about 1 to 2 months. They can fix and follow only horizontally, but after the age of 3 months they can fix and follow vertically in all directions as well. The two quantitative measurements can be, one is OKN and VEP. In OKN there is a black and white pattern which would be that would elicit a nystagmus, and VEP is the only clinically objective test for assessing the visual acuity. Now, when the child is over 3 months up to the 6 months of age, apart from these 9 tests, we can do 5 other tests as well. The first one being fixation behavior, and look for central steady maintained fixation, look for menace, reflex, Bruckner's test, and cover uncover test. So this method of testing for doll's eye was taught to me by my mentor, and here we can see that the child doesn't have a doll's eye. That is normal because the child has already developed a fixation, and we need to always look at the fixation behavior, whether the child is able to grasp the object or not. And then we need to look at whether the fixation is central, whether it is steady and it is maintained as well. Can be done with both eyes binocularly, and then you have to cover one eye and do unilaterally. Now in this child we can see that when I cover the right eye, the child is very comfortable, but when we cover the left eye, the child is trying to go away from it, and the child is resisting closure of the left eye. So in that case we need to have a suspicion that probably the child has a poor vision in the other eye. Menace reflex is when a sudden some threatening input is shown to the front of the eye, the baby will blink, and that is also an indication of good vision, which usually develops only by 5 months of age. Now, it's similar to doing a distant direct ophthalmoscopy, but when we observe both the eyes together, we get what is known as a Bruckner's test, where we have the compare and we look at the asymmetry, and we can get an idea of the media opacities and the anisometropia and things like that. Now coming to the cover and uncover test, and this can be done in children more than 3 months of age and can identify any phorias and tropias. Dr. Rashmi will throw more light on it. Coming to after the 6 months of age until 1 year, apart from all these tests, we can do 2 more tests which are more quantitative, and one they mainly depending on the preferential looking test method, which either Liag ratings or Teller visual acuity cards. We need to look at which thinnest stripe which the child is attracted to. Also, the Catford drum test also works on a similar principle, and the drum, when it is rotated, the smallest dot which attracts the attention. We know that all neonates need not be prescribed their glasses. The AAO recommendation is that only when myopia is more than -5 diopter, hypermetropia more than +6 diopter, astigmatism more than 3 diopter cylinder should be prescribed. But when there is an esotropia, a hyperopia of more than +2.5 diopter has to be prescribed, and whenever there is an anisometropia, the numbers are much lesser. So visual problems in infants are very important to be detected early because they can cause developmental delays, and we need to detect them early and treat them to ensure that babies develop visual abilities that plays a major role in the overall growth and development of the children. Thank you very much.
Thank you, Dr. Anitha. I think we can take the questions in the end. Now I invite Dr. Laila Mohan for a talk. That child referred from neonatologist as abnormal red reflex. Is it congenital cataract? Dr. Laila Mohan is the Chief of Pediatric Ophthalmology, Contrast Hospital, Calicut.
Thank you, Dr. Ashok. Uh, Thank you, Dr. Anita, for including me in this session, which is very important. The abnormal red reflex, is it cataract? So, observation of red reflex is a simple way to detect any gross amblyogenic issue in an infant. Media opacities like cataract, corneal opacity, which need immediate attention, and also high refractive errors, strabismus, or any intraocular tumors also can be screened by a red reflex screening. And light passing through the media, the tear film, cornea, aqueous humor lens reaching the retina and then back, any opacity like corneal opacity and cataract shows as a dark dull reflex, and is any asymmetric refraction. As you see in this first case, there is a light crescent superiorly which shows that it is a hypermetropic, high hypermetropia. Here there is a brighter left red reflex which shows that there is an strabismus. This is esotropia. Asymmetric reflex right is brighter, meaning it is anisometropia, right being the more ametropic one. And this yellow reflex is that of a retinoblastoma, yellow-white, chorioretinal coloboma. All these can be detected by doing, as Dr. Anita has already pointed out, red reflex screening test is ideal in the neonatology department as soon as the baby is born. So, a neonate with, is it cataract? Should the child be seen immediately? So, it all, in a child who's referred, whether an immediate intervention is needed or not, it all depends upon whether it is total, partial, bilateral, unilateral. In this case, where there is a bilateral total cataract, where there is no reflex, red reflex at all, it's a bilateral case. Here you can see the red reflex in one eye, the other has a partial cataract. So, a total cataract, whether it is unilateral or bilateral, it may all come down to timing. So, it's an emergency. Very few cases in a newborn are considered emergency. So the child is said to lose one line of visual acuity for every 3 weeks, that the surgery is delayed in the first 14 weeks of life, as shown by Scott Lambert. Unilateral cataracts are best operated by 6 weeks and bilateral by 6 to 8 weeks. Up to 8 to 10 weeks also can be bilateral cases. But if you prolong beyond that, beyond 3 months, they develop nystagmus, and then you cannot expect vision beyond 6 by 60. So now we know aggressive treatment of amblyopia with contact lens and patching can give good vision even in unilateral cases. There was a time when we used to say, if you do cataract surgery and if you leave them as a phakic, there is no point doing surgery. So now it's not so. Even unilateral cases can get good vision. So partial cataracts, the scene is different. Many cataracts look very subtle changes are there. If they are not visually significant, what is a visually significant cataract? This is a cerulean cataract, some sutural cataract is there. Posterior polar, just sort of Mittendos cataract is there, cerulean cataract. This is a little more than 3 millimeter posterior polar cataract affecting the nodal point. This is an anterior polar pyramidal cataract. So, some cataracts affects vision. So a 3 to 4 millimeter central posterior polar posterior, which is affecting the nodal point, the posterior polar posteriorly located one, affects vision. And if it is obstructing your fundus view, definitely you have to do surgery. And if the child is presenting with a strabismus, then definitely you have to do surgery. And if the child has an nystagmus, these are considered visually significant. If there is an anterior polar cataract, there is just a small pinhead sized cataract, even with the pyramidal one, they don't usually affect vision, and even fundus examination doesn't obstruct your visualization. They can be watched after putting you can probably see them every 6 weeks with some dilating drops to see whether it is progressing. But all these scenarios, they don't progress clinically, but you can bring them back in 6 weeks to 3 months and see whether there is any progression. Even Mittendos dots, they don't progress, but posterior polar look for progression. At a later date, they may progress into the first or second decade, first decade or second decade. So, coming to evaluation, bilateral cases, family history is very important, and examination of the family members also. In the parents, it's very important to look at the parents also. Genetic causes can be the reason in about 50% of the cases. And in our scenario, infection is a very important cause. Torch titers have to be done. Aminoaciduria, galactokinase deficiency is not very common, but often they have other systemic associations like liver pathology, low weight gain. All these problems are also there. So, reducing substances in urine, all these things can rule out metabolic disorders like galactokinase deficiency. In a unilateral cataract, you have to look more for pathology in the eye, like PFV, persistent fetal vasculature, posterior polar cataract, posterior lenticonus, rubella. Rubella also can present unilaterally, trauma, posterior segment tumors, and sporadic sometimes. So, what we have seen is persistent fetal vasculature is a very, very common cause for unilateral cataract. So, you have to be on the watch out for any persistent fetal vasculature and rubella and its associations. So, often in both these cases, the eye may be microphthalmic in PH, persistent fetal vasculature, not so much. Still, often we see the eye is microphthalmic compared to the other eye, and they can go in for glaucoma at a later date. So, they need more close follow up for development of amblyopia as well and glaucoma development. So, they need more frequent follow up of refraction and glaucoma. So, some challenges in rubella cataract. Rubella used to be the more common infectious cause. An LVPI study recently showed that more than rubella, it is the CMV that is coming up. Even in our study also, we have shown that CMV titers are more, 24% and 22% rubella. After the rubella vaccination has become more prevalent, I would say. It has not become compulsory even as yet. So, microphthalmia, myotic pupil, calcific capsule, all these are problems we face when we do surgery for rubella cataract. Corneal opacity may be there. Corneal, rather more than corneal opacity, I would say corneal haze is common. And glaucoma, pigmentary retinopathy, all these things affect their visual outcome. So, and also pre and post-operative anesthesia challenges in the rubella child. So, modern safe anesthesia has made it possible even to take up the surgery for cataract even immediately following cardiac surgery. We do surgery, they send us patient immediately the very next day saying he is fit for surgery after PDA ligation. So, we do surgery next day, but we do have to follow them up. We send them back for an ICU monitoring for 1 or 2 days. Surgery may be, we have to get prepared for hypothermia, postoperative apnea, hypothermia, and sometimes anticholinergic syndrome after using even hometropin, not even atropine. So, an ICU management may also be necessary. We have a hypothermic, this warming sheet for the baby for the during anesthesia. So, ophthalmic evaluation, of course, we have to do an on the table before surgery. In some cases, you have to rule out intraocular pressure also, right? Like rubella, Lowy syndrome. There may be an association, especially when you see a hazy cornea, you have to rule them out also. And biometry, axial, like I think I will rush. So, visual access opacity, you have to do an examination under anesthesia before surgery, and sometimes axial, you can do ultrasonography even before anesthesia to look for any posterior segment tumor or posterior segment fetal vasculature, even without anesthesia you can do. So, visual access opacification is the single most important complication which reduces visual acuity and lead to amblyopia after cataract surgery. So, PPC is a must, and the technique I'm not going into. And this is what our experience, that there are plaques which may be a residual remnant of PFB. 60% of our unilateral cataracts have these plaques, which may be due to PFB. Often we are able to put an implant an IOL. This is an we use endo-cautery for these vascularized fetal vasculature which we see on the cataract, and then go ahead with cataract surgery so that we can prevent bleeding. But before that, we have to rule out any posterior solely posterior vascular form of PFB when posterior segment surgeon will take over. So the whether we will implant an IOL or not before 6 months, the IATS has shown that it is the visual outcome is more or less same, but you may need more number of surgeries due to the membrane formation. But you have to know that the study which they did, they had to provide about 9 to 11 contact lenses during the first year after surgery, which was included in the study, which is not possible in our situation. So contact lens is not very feasible in our situation. So if the parameters like corneal diameter and the axial length, they are not microphthalmic, then probably even before 6 months you may be able to implant an IOL because the amblyopia management becomes easier. But after even before 2 years, after 6 months, the extension as an extension of the IATS, infant aphakia treatment study, the toddler aphakia and pseudophakia study, tabs have shown that IOL implantation is good. All this is because the cornea flattens from 52 to 43 diopters, 34 to 18 diopters of lens power, axial length from 17 to 22 millimeter. All this happens within 1 year, the first 1 year. That is why there is a lot of unpredictability during the first year. That is why implantation is better deferred in these cases. But of course, management is difficult when there is a unilateral aphakia with contact lens, and patching is always difficult. So if it is possible, it is better to implant an IOL. And secondary procedures, when you have to do a secondary IOL, in the sulcus, 3-piece IOL with an optic capture as you see here, or membranectomy may have to be done. And follow-up is the most important. We have what I call in our part of the place, Malabar, we have the Gulf syndrome. After cataract surgery, they just go to the Gulf and come back after 3 years with a thick membrane formation, no change in refraction, sometimes glaucoma. You see this unilateral glaucoma, unilateral cataract child had a microphthalmia, and they thought the eyes are becoming equal in size, and were very happy that they are becoming normal, and they didn't bother to come. And then he went in for glaucoma. Glaucoma was there, advised, but they didn't come. So all the refractive growth is very unpredictable in a child unless patching is done with the refractive correction. The unilateral cases can land up with dense amblyopia and all the risk we have taken during the first 3 months for surgery will become futile. And posterior capsule opacification and secondary glaucoma are still the major post-op complications. So long-term follow-up and counseling, each time you have to reinforce the need for follow-up each time. So thank you. Sorry for taking longer time.
Not at all. Yours was a keynote address, so we have allotted 10 minutes, I think. Thank you very much, Laila ma'am, for that very clear, insightful talk on abnormal red reflex and on management of congenital cataract. And next, I call upon to stage Dr. Thomas George, who is the senior glaucoma consultant at Chaitanya Eye Hospital. When we see that many a times we get, our colleague feels that isn't the cornea slightly larger than normal, so we always doubt whether this child would have a congenital glaucoma. Over to you, sir.
Thank you, Anita. Good afternoon. When one sees a cornea as being too large clinically, the real suspicion we have is the dangerous one, that's glaucoma. We go for the symptoms. In a congenital glaucoma, it's usually a photophobia, watering, and haze, or because of the corneal edema, and of course there will be blepharospasm because of photophobia. In children, IOP rise can expand the cornea, and that's why the cornea is big. But quite a bit can be achieved with an office exam. And intraocular pressure, I insist on a GA in a child who is pre-verbal, because any amount of sedation, the moment the paracaine goes in, the child wakes up and starts squeezing the lids. The only way you can get the IOP numbered is to get your resident to do it, who is forced to give you a number. I don't believe that. A reasonable slit lamp examination, however, is possible using this so-called flying baby technique, where you got the baby wrapped with arms and legs all nicely tucked in so that they can't flay it around and fall down. I have two people, not one like this. One person holds a baby sort of prone, and the head can be hyperextended, and you can use a slit lamp and examine the anterior segment. What do we look for in the anterior segment? Cornea, of course, edema, Habs striae, posterior embrytoxon, other iris anomalies may be there, axonfil rigor, aniridia, problems with the lens. As far as glaucoma is concerned, a spherophakia and a subluxation. Rest is Leila Madam's problem. With a reasonable suspicion, we post the child for an EUA, and if there's a reasonable suspicion that this is a glaucoma, we post for an EUA with the consent to proceed to glaucoma surgery, unilaterally or bilaterally, so that we do not risk induction and recovery from GA, which is more dangerous as the very next week. So EUA, the first thing is always intraocular pressure. GA medicines do alter IOP, and low is expected with sevoflurane and nitrous. Higher is expected with ketamine, especially immediately after injection. So wait a little bit if you're using ketamine. And just after scoline, again, after some time, it does come down. So factor these in when you think about the intraocular pressure. And what is normal in an infant newborn, you're expecting 10 to 12. Anything higher, there should be a red flag. And by 7 years, the average is 14. So consider high teens as abnormal, and definitely operate if it is above 20. On the microscope, we can use a handheld slit lamp also. What you're looking for is anterior segments findings like this Habs striae here. I think that's fairly obvious. There's a Habs striae going right across. And next, we look for the physical parameters of the eye itself, starting with, of course, the corneal diameter. And we record the white to white diameter, horizontal and vertical. Normal in a newborn is 9.5 to 10, and above 12 is considered abnormal. And at any age, as the child grows up, the corneal diameter also is expected to increase, but at any age, above 13 is considered abnormal. That's the white to white, and this particular child had 13.25, and that is a 4-month-old child. So that's abnormal. In primary congenital glaucoma, the scleral spur is not visible. In the normals, the iris would recess back, and the scleral spur should be visible. That's the primary thing you're looking for in gonioscopy. Also, the iris anterior edge as it inserts will be scalloped. You may have the wraparound or concave or convex. All three iris insertions are possible. And a lot of other findings like the morning mist where it's hazy, where the iris root is. Loch Ness Monster sign is where you have loops of normal vessels popping in and popping out of the trap meshwork, etc. So I use a mirrored gonioscope because it's easier with our regular microscope, and that's a gonio going in, and you can see the scleral spur is not visible. Anterior edge of the iris is scalloped, and the trap meshwork is fairly featureless. That's your morning mist. Disc will be cupped, and it does reverse in children because most of it is due to the stretching. Use an indirect ophthalmoscope. Forget about all the designs and features of an adult glaucoma. You do not get them in congenital glaucoma, at least in the earlier stages. And a normal cup disc ratio, again, in children or infants is 0.1 to 0.2. So 0.5 can be considered big, and a bigger one is, of course, abnormal. And here, just to show the disc, I'm showing it through the gonio mirror, but we do assess the disc with an indirect. This is a large disc, but If you think of it as an adult, it does look like a healthy disc, but this is a large cup for a child. We also need to do refraction. Astigmatism and myopia need calculated corrections of the refraction numbers, and there is emmetropization by the flattened lens, in the sense that when we do an axial length, we expect this much for a myopia of this much, but that you don't get that because the lens is flattened out. Axial length again is recorded, and these are primarily recorded with an intent to follow up after treatment, because with IOP lowering, these numbers also come down. Management, primary is surgery often. Trabeculotomy is what I prefer as a first step. Goniotomy can include the new suture gap, and trabeculotomy with the trabeculectomy is also done quite often. In follow-up office visits, we observe the child's behavior to assess vision. We ask the parents historically how the child is performing, as well as look for amblyopia. Also assess possible need for further surgery and follow-up EUAs, such as corneal haze, enlarging cornea, etc. And on follow-up EUAs, I do my first follow-up EUA after a surgery at 3 weeks with the intent of taking out sutures as well, because any paracensis in an infant needs a suture. It's not like an adult. It's too elastic, it'll stay open. If okay, then we go on to an EUA at 3 months. If okay, 6 monthly till the child allows applanation. Usually most kids allow applanation by 3 years of age, but I do have spoiled children who need EUAs even at 12 years of age. I'll skip this. Thank you.
Let's welcome Dr. Ashok from Precise for his talk on ROP screening. Thank you.
Yeah, thank you, Dr. Anita. Thank you, KSOS, for giving me this opportunity. The talk is basically about a precious preterm baby and how to go about ROP screening. Now, why we should go for ROP screening is because ROP is a potentially blinding disease, and it usually affects the preterm, born 4 or more weeks preterm, and has had a very adverse neonatal course. Okay, so when we talk about ROP, we talk about what is called a sight-threatening ROP. And we have the Rashtriya Bal Suraksha Karikram. Now, ROP is part of our child welfare program, and it has been intensively taken up by the government of India. So that is the importance that ROP is being given now. Now, we have the National ROP Task Force and our ROP operational guidelines. So this enumerates certain risk factors. The most important risk factor is preterm birth, exposure to excessive oxygen, sepsis, intraventricular hemorrhage, respiratory distress, failure to gain weight, blood transfusion. So this importance is failure to gain weight. So even if the birth weight is relatively normal, in the first few weeks the weight gain is not adequate. That itself is a risk factor for ROP. Now, whom to screen? This is the national guidelines, what I'm talking to you. Gestational age of 34 weeks or less, gestational age of more than 34 weeks if exposed to risk factors. Those are the risk factors I talked to you before. And if the gestational age is not known, birth weight of 2000 grams or less, other preterm infants at the discretion of the neonatologist. So practically, whenever you have a doubt that the baby can have ROP, you should screen. It's not that, birth weight or something. So importance should be given to gestational age at birth. Now, if the gestation age is not known, then comes birth weight, and then comes adverse neonatal course, and then comes if the pediatrician feels that the child is not okay, then it should be screened. So the number of babies who are going to be excluded from ROP screening is becoming less and less and less. Now, when to screen? First screening should take place by 25 to 30 days of life. That is 4 to 6 weeks of birth. First screening should take place. Now, there is something called as a GROP guideline. So, this is applicable only to developed countries. So, we are a developing country. This applies to developed countries. And if they say if you follow this, there is a 100% strike rate of picking up ROP. So, what they talk about is birth weight of less than 1051 grams, gestational age of less than 28 weeks, 3 measures of slow postnatal weight gain. So, see, in developed countries, many of the birth weight is relatively high. And when they have a reduced weight gain less than what is expected, that itself is a risk factor for ROP and presence of hydrocephalus. So this they particularly say because the oxygen therapy in developed countries is very much, they give blended oxygen. That is, they don't give pure oxygen. It's a mix of normal air in the ICU and oxygen. So in developing countries like India, the oxygen concentration or the facility to give blended oxygen is very less. So that blended oxygen is a must in these guidelines. So in India, we don't give always blended oxygen. So GROP guidelines is not applicable to developing countries like India. Now, how do? You need to have a dilated exam. The concentration of tropicamide is 0.5%. And phenylephrine is 2.5%. So that is a mixture we give. And the baby should be fed at least 1 hour before the screening. And a trained nurse must monitor the vitals. So if the child is not really well, you have to go to the NICU and do the screening. If it's relatively stable, the child can be always brought to your OPD. But provided in the ideal situation, you should have a pulse oximeter or something connected, and somebody should be monitoring the vitals of the baby. Now, the basic thing of screening is whether the child has got a sight-threatening ROP or not. If a baby has got a sight-threatening ROP, it requires treatment. So that is the basis of doing this screening. Then you have different things like zone, stage, extent and all that. Now the importance is zone and stage. Extent is number of clock hours. It's not much of importance in the present ROP screening. Now we have the IC14 guidelines, which are the new guidelines, which says new classification, which says posterior zone 2. That is a new concept that has been included. Then you have something called as a notch. Then you have incomplete vascularization. Now we talked about immature retina. Now it is called incomplete vascularization. Now earlier we have the aggressive posterior ROP. Now it is called aggressive ROP. Then we have stage 5. It is A and B. That is open funnel, that is a total retinal detachment, the end stage of ROP. Initially we had only open funnel RD and closed funnel RD. Now you have a classification called C also, which means there is an associated anterior segment changes. Now you have something called as a reactivated ROP. ROP which has regressed now has become active. Like in zone 2, the ROP has reactivated. So reactivated zone 2 ROP, like that. And FA and OCT has also been now included in the diagnosis and evaluation of ROP. So these are the new things that have come in the new IC ROP criteria. Now the basis of this thing is there is an increasing recognition that ROP may occur even beyond the posterior retina, and we are now seeing larger preterm infants, and it is more common in developing nations with limited resources, like basically because of the oxygen concentration. Now we have 3 epidemics: the first epidemic, second epidemic, and the third epidemic of ROP. The first and third epidemics are almost similar because it is based on the kind of oxygen that is being delivered to babies. The second epidemic was due to early salvage of preterm infants. So that oxygen is the main thing that in developing countries, which is the issue. So posterior zone 2 means somewhere between zone 1 and zone 2, 2DD area, and it means more worrisome disease. Notch means the ROP has incurred in encroached into a more posterior zone by 1 or 2 clock hours, and this means less worrisome disease, means a limited incursion into a more posterior zone. And the most important thing is plus and pre-plus disease. So when you're screening, when you see the posterior pole vessels are dilated and tortuous, that means the baby is going to have ROP. The importance is you don't even have to see the peripheral retina. You just see the posterior pole, dilated tortuous vessels and engorgement of anterior segment iris vessels, and you know the baby has got plus disease. Plus disease means the child will have treatable ROP. So this is a photo of plus disease, just 2 minutes. And what kind of ROP you treat? According to the early treatment ROP trial, it is type 1 ROP. So any ROP with plus disease, you have to treat. Zone 1 ROPs, you have to treat. Then stage 2 or stage 3 ROPs, neither zone 1 or zone 2, you have to treat. So plus disease, plus disease, plus disease, that is the most important thing that you have to see while screening the baby. So zone 1 and 2 risky plus disease risky. These are some of the photographs. How to assess the zones like central area zone 1, nasal aura up to the temporal periphery zone 2 and far temporal periphery is zone 3. So these are some of the things. And aggressive ROP, rapidly progressive ROP. It will not pass through the various stages of ROP because there will be incomplete vascularization of the zone 1 and zone 2. It will be flat. It will not be elevated like the usual ROP. You will feel it's immature retina, but it is very aggressive or advanced ROP. And unless it is treated within 24 to 48 hours, it will lead to permanent vision loss. So these are some of the things, and these are the complications of ROP. You can have RD, you can have, atrophic retina, myopia, all those things. And there is something called ROP-like retinopathy, which occurs in near-term infants. And they may be near normal birth weight. There are a lot of theories like, sudden decrease in blood flow or a closure of the PDA or the foramen ovale or the imbalance between the metabolic and nutritional need of the retina. All these things can lead to an ROP-like retinopathy even in term infants. Now, should we do universal screening? Now, there's been a study, they screened all babies, normal babies, and they found that 20% had retinal hemorrhages and 0.14% babies had ROP-like retinopathy. So, that is something to be pondered about. Other differential diagnoses like FEV or Coats disease also have to be kept in mind. Thank you very much.
Thank you very much, Dr. Ashok, for that wonderful talk on ROP and about the recent aspects of it. Now we have our Dr. Rashmi Bhaskar coming up to talk, give us an insight about the management of squint, which most of us are doubtful whether to refer to a strabismologist or can we wait until 1 year. So let's see what Dr. Rashmi has to speak about it.
Thank you, Anita, for giving me this opportunity. Let's start with a lighter note. Should all children with infantile squint be referred for surgical correction? We will navigate through few cases and see whether it is a yes or no for surgery. The photos and videos shown in this are taken with the permission of child's parent. This is a case, one is a 2-month-old child, mother is a doctor, mother feels occasional squinting. It's a full-term normal delivery, external eye was normal, social smile was present. So what is it? It's a neonatal misalignment or physiological intermittent strabismus of the newborn. Up to 1 month, fixation will become central, steady and maintained, and by 3 months, binocular vision will develop and will have a coordinated eye movements. 88% of the infants will show brief periods of intermittent squinting. It will be intermittent, not constant. The deviation can be large but short-lived. It can be unilateral or alternating, and usually it will resolve by 2 months. So, if any child presenting it to you with a squinting more than 3 months of persisting more than 3 months, or if it is constant, that needs a follow-up. So what you will do for this child, you will ask them to come for a follow-up and see if it has resolved fully or you need further follow-up. The second is a 8-month-old child. The mother has felt that in all the photos, the child has a inward deviation of the eyes. Hirschberg was orthophoric and the cover test showed no refixation movement. Refraction and fundus was normal. So it is a pseudo squint. As you can see in this video, we are doing a cover test. There is no refixation movement. When the child is small, you can do even with 2 fingers. The normal infants will have a wider and flatter nasal bridge, and this will give an appearance of a pseudo squint. Before you are labeling it as a pseudo, you call them again for after 2 months to reassess, because it can sometimes be an intermittent squinting with a good fixation that has not shown up in your first visit. So you always call them one more time and reassess before labeling them as a pseudo squint. This is a 4-month-old child. You can see a large squinting is there that has been noticed from birth, full-term delivery, and Krimsky shows almost 60% of esotropia, cross-fixation, normal refraction and fundus. And it is a case of essential infantile esotropia. This particular child with large angle squint, cross-fixation and normal refraction, you have to plan for a surgery early. The surgery plan from 6 months of age, surgical intervention can be done as shown by many studies. The advantages are better stereopsis and early binocularity, reduce incidence and severity of postoperative DVD and IO overaction, minimize the delay in sensory motor and motor development, and improve psychological and parental bonding. So, infantile esotropia, you have to plan for an early surgery. This 5-month-old child with also an inward squinting. You can see the squint in the left eye, intermittent it was, fixing and following well. External eye was normal, fundus is normal, but here the refraction was +5.
Accommodative esotropia can occur early also. It's an early onset of accommodative esotropia. Studies have shown that 15% of the infantile esotropia and 8% of the accommodative patients have an infantile accommodative esotropia. So, cycloplegic refraction is a must for all children who comes to you with squinting. You can ask them for a atropine refraction, or whichever cycloplegic, you have to give a cycloplegic refraction, and if the hypermetropy is more than plus 2.5, you have to give glasses. They see this child, they have come back with the glasses and she is orthophoric. The next is a 3-month-old child, squinting noted since birth. This is a divergent squint. Head control has been attained, but it's a constant exotropia. Almost 40 to 50 prisms is there, freely alternating. Refraction fundus is normal. This is a case of congenital exotropia. This is also a large angle, but they have poor binocular potential, and in case of congenital exotropia, you rule out neurological problems. And early surgery is advised in this child also. This child, 11-month-old, was referred to us from Sri Chitra with a history of developmental delay, facial dysmorphism and microcephaly. It was preterm with birth weight of 1.6 kg. You can see a alternating esotropia, right convergent to alternating. Refraction fundus was normal. But in spite of all this, the child is easily allowing you to do a cover test, and you would get a good measurement with the Krimsky also. The child was willing for allowing all that. So this child also should be referred for surgery, because surgical surgery for children with developmental delay, they well tolerate and effective. Only thing is the angles can be variable. You are sure when you get a correct measurements and you feel that it is constant, you can plan for a surgical correction. Depending upon the assessment, and angles are, if normal, angles are stable, and if you, after you get a neurology fitness, you can plan for a surgery, because they have a chance of fusional potential. It improves the quality of vision and life of the child. So this case is, I am showing two cases. One is a 1-year-old child, preterm, 24 weeks, status was ROP laser. He has an alternate convergent squint. The other baby is a 9-month-old, that also preterm with no retinopathy prematurity, with intermittent divergent squint. When you check the refraction, both are high myopia, and squint and refractive error is common in preterm children. And so in preterm children, in addition to going for an ROP screening, you ask them to come back for refraction and squint evaluation at 6 months, and the risk increases with the severity of ROP also. So in this child, we have given the glasses and advised patching, and depending upon how they are doing with the glasses, we can plan surgery accordingly. This is a 7-month-old child with the left eye squinting constant, and she was resisting occlusion of the right eye, showing that the left eye has a poor vision. Fundus examination showed a coloboma. These are some of the common fundus findings we have come across in children who presented with squint, optic atrophy, ROP, retinoblastoma even in a 6-month-old child, vitreous hemorrhage, choroiditis, and familial exudative vitreoretinopathy. All kids coming to you with squinting, you have to do a fundus evaluation. That is mandatory. If at all the child is not allowing or anything like that, you plan for a examination under anesthesia, but you cannot miss a fundus finding of grave conditions like this. 6-month-old child, mother noted squinting and normal milestone. On examination, you can see there was a face turn to left. When the head posture was corrected, he had an esotropia with -2 limitation of abduction. Refraction and fundus normal. It is a case of Duane syndrome. In congenital cranial disinnervation disorders also, the indications for surgery are abnormal head posture, squint in primary position, upshoot and downshoot. So after you get a good measurements, you can plan for a surgery, even indicate. This is slightly older children, 1.5-year-old, but still because of the importance of this case, I am showing this. Complaining of squinting right eye, and he gives a history of subcongenital hemorrhage at the time of birth, forceps delivery. See, she is resisting occlusion of the left eye, but when the right eye is closed, she is allowing it. That is with the right divergent squint, showing that the right eye is amblyopic. She had a cataract in the right eye. As madam has told, cataract also external eye examination you can do with the help of a Bruckner test, direct ophthalmoscope, handheld slit lamp, and for courageous person like Thomas, you can use a flying baby technique. I am still scared to do that. Or if you have any doubt, you plan for an examination under anesthesia also. So prevalence of squint in children with congenital cataract is around 20 to 80% before and after surgery. It can be ESO and exotropia. Other visual deprivation factors include corneal opacity, dense PPM. This have to plan for a cataract surgery at the earliest and amblyopia treatment also. Some studies show that you can combine cataract and squint surgery also, but that is controversial. The last case, it's a paralytic squint in children. If a congenital palsy, fourth nerve is the commonest, but in case of acquired causes in infants, it is a red flag. It can be a sign of hydrocephalus, brain tumors, or demyelination. So you have to send for an urgent neuro evaluation and imaging. A study showing the profile of infantile strabismus at a tertiary eye care in India, it shows that 123 children out of 4773 had infantile squint. Boys and girls had equal preference, and esotropia was the commonest. And esotropia was common in prematurity, hypermetropia, and anisometropia, and exotropia in seizure session, delayed cry at birth, infantile seizures. And out of the 123, 29 underwent squint surgery. Take home message is constant squint or squint persisting more than 3 months is significant. Cycloplegic refraction and dilated fundus is mandatory. Constant large angle squint need early surgery. Timely referral and early surgery can preserve binocularity. Thank you.
Thank you, Dr. Rashmi. Now I invite Dr. Anju Suresh, consultant orbital oculoplasty at Chaitanya Eye Hospital. Can an infant with epiphora be managed in a general ophthalmology clinic?
So good afternoon. Today's talk is about any infant with epiphora presenting to a general ophthalmologist. So can it be managed? About 90% can be managed by the general ophthalmologist because it usually resolves on its own. So when a child presents with tearing, the differential diagnosis will you should consider the associated symptoms. So if there is tearing with discharge, think of congenital nasolacrimal duct obstruction. If there is tearing without discharge, that means the obstruction is higher up. Look for an impatient puncture. If tearing is associated with photophobia, always rule out infantile glaucoma. And then tearing with pain. Look at the lid margin carefully. If there is blepharitis, think of staphylococcal keratitis, or look for a tracheitic lash, epiblepharon, congenital entropion of corneal foreign body, a corneal aberration, anything causing pain. And rarely, tearing with photophobia and torticollis can be associated with a posterior fossa tumor. The reason is not clear, but it's a known association. So the normal nasolacrimal excretory pathway, you all know, it starts from the superior and inferior puncta, drains into the canalicular system, then into the lacrimal sac, and finally into the nasolacrimal duct at the opening at the inferior meatus. So brief look at the embryology of the nasolacrimal system. So it starts as a surface ectodermal thickening at 32 days, that is 4 weeks, 4 to 5 weeks, and it becomes well differentiated, cord-like, it gets buried in the mesenchyme and canalizes at 60 days. So as this picture shows, canalization starts in the center and proceeds towards the ocular end and towards the nasal end. So any congenital lesion, you look for occlusion at the ocular end, that is the puncta, or at the nasal end, that is the inferior meatus. And as this picture shows, it's often associated with other mid-face abnormalities. So this is a baby presenting with CNLD. You can see the purulent discharge at the medial canthus in the left eye, and there will be mattering and crusting around the eyelashes. Another particular feature is that it will be of chronic duration and the child will be usually unbothered by her problems. If it is just tearing with watering and no discharge, then look for a impatient puncture. So how will you do screening for CNLU? We have to do a Ropless test or regurgitation pressure over the lacrimal sac. So the method is you first palpate the inferior orbital rim and then trace the orbital rim superiorly and medially till you reach the anterior lacrimal crest, and then apply pressure, sustained pressure with your index finger in a superior and medial direction for 45 seconds. If there is regurgitation, that is indicative of nasolacrimal duct obstruction. Also it indicates that the puncti and the canalicula are patent. I'm not getting the videos. Excuse me. I'm not getting the video. Thank you. So this is testing for O+ in a baby. It becomes more time consuming, but again you palpate the medial end and you can see the pus coming at the medial end of the canthus. So what is the advantage of O+? It's a very useful, easy, non-invasive screening test with a 93% sensitivity and 99% specificity. So the next test that you can do is a fluorescent dye disappearance test. So if there is Rho+ negative and still the patient complains of epiphora, then instill fluorescent in the conjunctival sac, wait for 5 minutes. If at the end of 5 minutes the fluorescent usually disappears from the conjunctival sac, but if it is retained, that means there is some obstruction in the lacrimal excretory pathway, and if it's Rho+ negative, then look for obstruction in the canalicular stenosis or punctal stenosis, etc. Now how will you manage? Most of it is conservative management. CNLDO is actually a variation in the normal development of the infant and not a pathological condition. So you can wait till normal canalization occurs, and conservative management includes lacrimal sac massage. If purulent discharge is present, you can apply topical antibiotics. Now high pressure irrigation is a method in between conservative and invasive, where you inject under high pressure and hope that the membrane at the inferior end of the nasolacrimal duct ruptures. Now the invasive methods include syringing and probing, placing a silicone stent, and ultimately DCR. Now this is conservative management. You have to advise the patient how to apply the lacrimal massage properly. So you ask the patient mother to hold the baby across her lap, holding the head of the baby in one hand and the chin in the other hand, and then place the index finger between the globe and the nose. Apply firm pressure over the medial canthus. Your intention is to occlude the common canaliculus and increase the hydrostatic pressure within the nasolacrimal sac, hoping that this pressure will open up the lower end of the nasolacrimal duct. So you apply pressure directed towards the opposite ear and then stroke the finger downwards towards the nose. It has to be done 10 times, morning, noon, evening and night. And this usually is continued till the baby is up to 12 months of age. Now this is a graph taken from a study that shows that spontaneous resolution occurs in 90% of babies in the first 3 months and continues to occur till the end of 1 year. After 12 months, the chance of spontaneous resolution usually plateaus and the need for an invasive procedure arises. Now, one of the rare situations where early probing is advised is an amniotocele. The baby is born with a collection of amniotic fluid or mucus fluid in the sac. This also means that both the common canaliculus and the nasolacrimal duct are occluded and usually manifests at 2 weeks age. So the problem with this is the baby can develop periorbital cellulitis. So to avoid that, we do an early probing. Now, when do you refer to an oculoplasty? When you have advised conservative management for 1 year and still watering persists with discharge, then you refer to oculoplastic clinic for primary probing, which can be done either as an office procedure. The advantage is there is no GA, but the chance of false passage is more. Or it can be done under an operation theatre under short GA. It can be done early as in an amniotocele or late as after 12 months. And the success of probing is inversely proportional to the age of the baby. So as the baby grows older and older, the chance of a successful probing becomes less. Actually, it's only 50% after 3 to 4 years. If you have an associated ENT department, you can do an endoscopy assisted nasal probing. Again, the chance of a false passage is less because endoscopically you can see the probe coming through the inferior meatus. Now, always the patient's parents have to be advised that one probing will not be necessarily successful. Repeated probing may be needed with silicone stent. Then you can also advise DCR, but we wait for DCR till 3 to 7 years. We allow the nasal bone to grow and we don't want our surgery to affect the growth of the nasal bone. Thank you.
Thank you very much, Dr. Anju, for that wonderful talk. I hope all of you who attended have taken benefit from the various aspects of examination of newborn and infants, and it will help you in your general day-to-day practice. Thank you very much for all the speakers for accepting my invitation, and I don't think we have much time left for questions as it's already time for the next session to start.